There's been a steady change in the approach and care of PE that has been noted over the last 5 to 7 years in the US, but also worldwide. And that seems to be spearheaded by a movement towards developments of pulmonary embolism response teams, so-called PERT teams. The concept behind PERT teams is to get acute PEs in patients hospitalized with PE into the hands of experts who can try to come up with the best possible recommendations for their care. And why they might be particularly useful in this field is that there are not really great comparative evidence for the utilization of various therapies, especially in those patients who have what we consider intermediate or high-risk pulmonary embolism. So specifically, high-risk pulmonary embolism refers to patients who actually are in shock with low blood pressures when they present with PE to the hospital. And intermediate-risk pulmonary embolism refers to those patients who are suffering from right ventricular dysfunction but have stable blood pressures when they're admitted to the hospital. So our document aimed to tackle this new field where there are several new devices coming out of treating PEs with endovascular therapies. Specifically, we categorize devices into 2 broad categories, recognizing that as we go forward in time, there will probably be substantial overlap between these categories with novel devices. Those 2 categories, broadly speaking, were catheter-directed lysis, or catheter-directed thrombolysis devices. This means the locally directed administration of thrombolytic therapies directly into the clots with the placement of catheters next to or through the clots in the pulmonary arteries. And then the other broad category of device was what we called catheter-based embolectomy devices. So these are devices that aim to very actively remove clot from pulmonary arteries. So after categorizing the devices into those 2 broad areas, we went ahead and reviewed all evidence that we could find for safety and efficacy of PE devices in this field, in this area. What we discovered is that there right now are a bit of competing safety profiles between catheter-directed lysis devices and catheter-based embolectomy devices, with the best available evidence showing that catheter-directed lysis devices carry small but relevant risks of major bleeding, including intracranial hemorrhage, at a low rate but a verifiable one when used in the management of PE. Notably, we went ahead and performed the first ever meta-analysis of prospective trials of catheter-directed lysis devices to assess what the rates of intracranial hemorrhage have been in these studies. And we found a point estimate of 0.7%. So a modest risk, but one that we still have to keep in mind. The trade-off when comparing to catheter-based embolectomy devices, in which we did not really see any signal for intracranial hemorrhage or really for major bleeding, was a different risk profile. And with catheter-based embolectomy, we saw that there was, again, a small but verifiable risk of hemodynamic or pulmonary decompensation. So when we're choosing between these devices, one of the key decisions we have to make is a choice between risk profile, bleeding on one side and the risk for decompensation on the other. When we looked at all of this, we had a hard time coming down strongly on in which patients these devices should be utilized in the intermediate risk population. It's clear that putting these devices in our hands in high-risk patients is probably going to result in benefits to patients, because this is a group of patients that has high mortality rates and without a lot, unfortunately, of options for them right now. For that reason, the next thing we decided to do was to make some recommendations about study design, and we divided our recommendations for study design into the high-risk group and the intermediate risk group. For the high-risk group, we decided that it was reasonable to design studies that are ideally prospective but could be single-armed. And the reason for that is we came up with a lot of potential issues with randomizing studies in this group. Just a few of these issues include the use sometimes of multiple therapies in the same patients. The second is the low volume of cases showing up to any single hospital, and the difficulty with then selecting out cases to randomize within that group. When it comes to the intermediate risk group, we thought there was a very different story here. Specifically, the relative spread or benefit risk ratio between efficacy and safety of these devices is narrow. We saw that there are roughly 1 to 3% chances of having major, even life-threatening complications with the use of these devices. And if you look back historically about what you would expect the spread and mortality benefit to be in these patients, it also would be in the 1 to 2% range on the absolute basis. When that window is that narrow, you really need to perform randomized studies.